Thank you for joining us. My name's Jo Booth, and I am a widow of a former patient of the IOZK. My husband was diagnosed with a stage 4 GBM back in 2021 to 2022. And we went over to Germany to have treatment with Dr. Van Gool. And I'm a big believer in the care and the treatments that they are giving patients. And I wanted to basically get involved with this and make sure that other people find out about the amazing work that they're doing, but also to sort of open up this discussion, because I found it very difficult when Chris was first diagnosed to have these conversations with his medical team, because there was just a lack of understanding about the work that the IOZK are doing or the other clinics. And I feel really that it's important that everyone starts to have these conversations and share ideas, ask questions, so everyone's getting an informed feedback about what's available. It was, it still is, sorry, we're on the 31st. I thought we were in April then. It's Brain Tumour Awareness Month, and that's why we've been hosting these webinars. And it's not just about raising awareness of what is a brain tumour, but it is also about raising awareness of what can be done. So this is an opportunity for everyone to share experiences, ask their questions about the work the IOZK are doing, and as I say, just generally an education piece for everyone to share ideas. The session is going to be an hour long. I believe Stefan's slides will take 35 to 40 minutes, and there'll be time for a Q&A. If you've got any questions, please do post those in the chat box, and we'll be keeping an eye on those as he goes through the slides, and then we'll come to those at the end. I will turn off my video in between as well, so I'm not a distraction, because I will be moving a lot, and then I will come back at the end. And yeah, please, like I say, ask questions as we go through. This is for you to get as much out of this as possible. So if you think of something, don't hold on to it at the end. If you're anything like me, you'll have forgotten the question by the end. So make sure to drop it in the chat. But without further ado, I'd really like to introduce you to Stefaan Van Gool. As I said, he was Chris's doctor at the IOZK, and I'm a firm believer in the work that he's doing, and I'm really excited to hear what he's got to say. So over to you, Dr. Van Gool.
Yes, thank you, Jo, and welcome to everybody. Indeed, thinking on glioblastoma care and sharing ideas and discussion points is a perfect match at the last day of the Brain Tumor Awareness Month, where we all have to be aware about this disease and the challenges to get an answer for the patients. The current story starts, in fact, always with the same challenge that neuro-oncologists face. Here, a 34-year-old female with a brutal glioblastoma, even at the end of pregnancy, molecularly defined in biopsy by IDH1 wild type, happily enough, MGMT promoter methylated, but still inoperable. And this is, in fact, a familial catastrophe, not only for the patient, but also for the surrounding. The challenge in the international research communities is really felt, and within the pediatric high-grade glioma working group of the International Society of Pediatric Oncology, we are setting up a new clinical trial protocol at the moment, and this protocol is more oriented to the tumor microenvironment, and the leaders of the protocol have asked us to write the rationale of the protocol. And in fact, this text has then been developed further and has resulted in our last publication published some weeks ago with the title The Complexity of Malignant Glioma Treatment. And this is a collaborative effort from several countries to put this text together. Indeed, GBM is a very complex disease. We not only have the heterogeneity within the tumor, having different tumor cell subclones, but we also have glioma stem cells, and we have a lot of other cells that really are dysregulated and support and maintain the tumor growth and the glioma cancer stem cell existence. So the heterogeneity is a big problem. The different mutational anomalies is also a big problem. And one of these mutational anomalies is playing also a crucial role in prognosis, namely the MGMT promoter methylation status. Methylated, that means the gene is closed and a repair enzyme cannot be produced, so that the radiotherapy and the chemotherapy can effectively kill cancer cells. While in the MGMT promoter unmethylated patients, the MGMT enzyme is produced and can create repair of the damage induced by radiotherapy and chemotherapy, so that the results of the radiotherapy and the chemotherapy are less good. On top of that, making it really difficult and uncontrollable is the plasticity of the tumor. So glioma cancer stem cells make subclones. These subclones de-differentiate again to glioma cancer stem cells, and then other subclones come up. So the intrinsic plasticity is an uncontrolled biologic process that is really occurring quite fast in the glioblastoma tumors. On the other hand, at the clinical level, the presentation of the patient can make risk profiles. So the age of the patient, the Karnofsky index of the patient, the mini-mental status of the patient, the extent of resection by the neurosurgery, the grading of the tumor, and also the quality of the radiotherapy, these 6 elements made it possible to make a recursive partitioning analysis and to make different risk groups of patients all having their own prognosis from bad to very bad. Besides these clinical risk profiles, we have also now availability of risk profiles at the level of the tumor host interaction, so the tumor microenvironment, and this is here only one example. There are several examples published in the literature. And again, similar to the plasticity within the tumor cell clones, you have also a plasticity within the immune system, because the immune system is damaged by the radiotherapy and the chemotherapy. And here, as published in 2020, you see that after the radiochemotherapy, your immune cell population here, the CD3 positive T cells, they really can go down, even in some patients to levels that you also see in end-stage HIV patients. So a real immune suppression and also a scatter. And this happens in an uncontrolled way. You cannot predict how the immune system of a patient is reacting to the radio anti-chemotherapy. You only can say if you add on top of that steroids, then this is really damaging your immune system. That's the reason why we always try to avoid steroids already during radiochemotherapy. The reality is therefore that we have a heterogeneity and dynamics within the tumor, that we have a heterogeneity and dynamics within the tumor microenvironment, and even within the host, so that it becomes extremely difficult to make clinical trials according to the classical clinical trial technology. Because of this heterogeneity, you would need a lot of stratifications, and we deal both at the site of the tumor and at the site of the response of the host to treatment with uncontrolled processes, making controlled trials extremely difficult and, in fact, not possible. The reality, however, is that you face a glioblastoma which causes clinical symptoms, and we should be aware that this glioblastoma intrinsically already causes immune suppression locally, but even systemically, you have an immune suppression. And of course, this is an acute and dramatic situation that should be handled in the appropriate way with an anti-cancer treatment. The neurosurgery remains extremely important. The radiochemotherapy and then the maintenance chemotherapy is aimed to further control residual tumor cells because the resection can never be complete. This is the standard of care that has been developed in 2005, published in 2005, and further in 2009 by Roger Stoop and colleagues, and this is the so-called Stoop regimen. They got significant shifts in the overall survival curves, red with radiotherapy alone, blue with the addition of chemotherapy during radiotherapy and after radiotherapy in both the MGMT unmethylated patients and with a better prognosis, as explained. Also in the MGMT promoter methylated patients, there is a significant shift due to the addition of temozolomide to the standard of care. So that means it's significant. We call that then evidence-based medicine, and that became the standard of care. The reality is that if you treat 100% of the patients here with MGMT unmethylated tumor, that half of them ultimately will live 27 days longer. So the relevance of the significance is rather poor, although it's now the standard of care. But there is even a little bit more. We know the plasticity of the tumor cells. We know that radiochemotherapy and maintenance chemotherapy can damage the genetic structure, which cannot be repaired eventually. So you get more mutational burden, you get more tumor cell clones that appear. Even if patients ask to me what can cause glioblastoma, then I have to say, well, radiotherapy can cause glioblastoma. Then the patients are shocked. But on top of that, at the same time, and that is what we see day by day, the immune system is further weakened by the radiochemotherapy and the maintenance chemotherapy, so that at the end, we make the patients in a balance that these new subclones that we partially have induced have a free pathway, not anymore blocked by any immune system, a free path to death, and that we do for 20 years. So our gain in the beginning is a little bit, but the programming of the patient is a free path to death. And the question is whether we should treat such complex dynamic tumors in complex dynamic microenvironments only with surgery, radiotherapy, and one or two alkylating agents. That can never be enough. On the other hand, we should ask ourselves if we can treat dynamic tumors in dynamic environments with fixed protocols, because the dynamics are never controlled. So we need to start thinking to innovative, dynamic, multiphase combination treatments. Maybe we cannot anymore call them protocols, and we should look in each patient what is happening with this patient, and we should sample real-world data. Our strategy is such a combined multiphase strategy. So we believe that we can add already immunogenic cell death immunotherapy into the first line therapy. This is a combination of oncolytic virus therapy and modulated electrohyperthermia. With these technologies, we kill cancer cells, But we kill now also glioma cancer stem cells, which are not sensitive to the radiotherapy and the chemotherapy, and we change the tumor microenvironment so that the immune system becomes alerted, becomes alarmed. And the concept of immunogenic cell death immunotherapy has been published in the literature, and I belonged to this international group of scientists who have published the guidelines for definition, detection, and interpretation of ICD, knowing that indeed we can kill cancer cells in a way that danger molecules appear and the antigens will be taken up by the dendritic cells. The dendritic cells will become mature and move to the lymph nodes. In the lymph nodes, the mature dendritic cells will present these tumor antigens to the CD4 and CD8 T cells, and these CD4 and CD8 T cells will generate an immune response so that cytotoxic T cells can act against the cancer. This is a general biological phenomenon that nowadays is recognized as a potential mechanism after radiotherapy, after some types of chemotherapy. It seems also a quite essential mechanism in the tumor treating fields, Optune, but also modulated electrohyperthermia. These are electromagnetic waves not in the kilohertz domain like in tumor treating fields, but in the megahertz domain. They also can induce ICD. And finally, oncolytic viruses like the Newcastle virus that we use can also induce immunogenic cell death. So having done this much more combined and integrated approach, the work seems not to be done, because now we have to block this pathway to death with an immunization, an active stimulation with active specific immunotherapy to block the growth of the novel and old subclones with the immune system. And we have to yield the antigens to which we have to create the dendritic cell vaccines. And at the same time, we do modulatory immunotherapy to facilitate the generation of the immune response. Let's first look to these antigens that we yield. Here is the dendritic cell vaccine approach. We can take monocytes out of the blood. We can differentiate them to immature dendritic cells. We can load them with antigens eventually that we can derive from the original tumor. We can make a maturation signal, and then the mature dendritic cell will be injected into the body, into the skin, intradermal injection, so that the dendritic cell will move to the lymph nodes, and in the lymph nodes, the activated dendritic cell will stimulate the immune cells to fight against the cancer. The dendritic cell vaccine approach has been developed and discovered by Professor Ralph Steinman from the Rockefeller University, who has helped me in person to get that developed for the glioblastoma patients. But you can also give this modulated electrohyperthermia and the bolus injections of oncolytic viruses to yield these little fragments, which we call antigenic extracellular microvesicles or apoptotic bodies or large oncosomes, and we can yield these fragments out of the blood to throw them on our immature dendritic cells as source of antigens, and then we can do the maturation step and the formulation into the syringes. So when we do this technology, we have the actualized tumor antigens in our dendritic cell at time of the production of the dendritic cell. And this seems potentially quite important, knowing the dynamics of the tumors and the change of the tumor mutational burden. And this concept has been developed here at the IOZK with Dr. Wilfried Stucker and Professor Volker Schirmacher. Now, if we see that, we come to an important point. What is, in fact, a vaccine? A vaccine contains three elements: an antigen, a carrier, and a danger signal. And as I've already said, Ralf Steinman has helped me to set the technology up for dendritic cell vaccination for glioblastoma patients. He won the Nobel Prize together with Beutler and Hoffman for the discovery of the dendritic cells on the one hand and the importance of danger signals on the other hand. There are a lot of sources of antigens nowadays available. There are also several carriers available, and there is knowledge of several danger signals. And one of the questions that I get many times from patients from the UK, but also from the US, is what is the difference between the vaccines produced by CGAT and the vaccines produced by the IOZK? The CGAT vaccines have computer-predicted, well-defined tumor antigens that they have defined in the resected tumor tissue that they receive from the patient. So the potential problem might be that the representativity of the piece of tissue that has been sent to CGAT might not reflect the whole picture in the heterogeneous tumor. And these tumors might not reflect maybe the antigenicity that changes after the radiotherapy and after the chemotherapy. The solution, the carrier, is water with DMSO, and the danger signal is GM-CSF with or without imiquimod. That is the definition of their vaccines. They had a publication in Nature Communication showing the effectiveness of their vaccine, at least the experience, were quite clear. The IOZK vaccine, they contain not computer-predicted, but real and actualized antigens, which we do not know, the antigenic extracellular microvesicles, apoptotic bodies, and large oncosomes. As a vehicle, we use autologous mature dendritic cells, and our danger signal is included in the laboratory so that we are sure that the dendritic cells react on them and that we have highly mature and active dendritic cells before we inject into the patient. This is active specific immunotherapy, and both CGAT and IOZK aims to stimulate actively the immune system against the cancer. That is active specific immunotherapy. We modulate the immunotherapy already at this stage because we know that there are regulatory molecules that block the immunization, and here we use already an anti-PD-L1 monoclonal antibody based on this publication here in Cell in 2024. And then after this second phase, the immunization phase, we need a third phase, the maintenance and expansion phase, because of the dynamics of the tumor. Again, new clones will develop, and also these clones has to be put under the protection of the immune system. So we have to expand our antigenic protection, and that we do with further courses of immunogenic cell death immunotherapy. We prevent T-cell exhaustion with modulatory immunotherapy, low-dose anti-PD-1 and anti-CTLA-4 monoclonal antibodies. We give some more universal long peptide vaccines, and we place somewhere also a boost DC vaccine. Outside that, we have to take into account the tumor microenvironment. About half of the tumor volume do not exist of tumor cells, but of other cells. And in our manuscript in 2025, we have made a reflection on these hallmarks of cancer and thought what can eventually be important in the formation of glioblastoma. And we end up with the metabolic reprogramming, the neuron glioma axis, the glioma cancer stem cells, the inflammation and immune suppression, and the bad role of hypoxia. And we can develop treatments against these hallmarks. This is the tumor microenvironment treatment. And I will not go into detail in the biochemistry and physiopathology behind, but glioma cancer stem cells can be stabilized with antidepressants. We know that hypoxia and the relation with the metabolic reprogramming makes cells resistant to radiotherapy and chemotherapy, and we have several elements that can be used to modify this negative influence. The metabolic reprogramming as such can be tackled with several drugs at several pathways, certainly to prevent the skewing towards fermentation, which is called the Warburg effect, leading to lactic acid production and making a very bad situation for the tumor. And several drugs can be used. All hallmarks, glioma stem cells, hypoxia, metabolic reprogramming ultimately result in an immune suppressive environment and the presence of wrongly functioning microglia and wrongly functioning M2 macrophages. And there are several approaches to influence here the physiopathological process. Ultimately, we know that the neuron glioma exists and that the electricity of neurons can sustain the malignant network of the tumor cells. So some anti-epileptic drugs try to block this electrical maintenance of the tumor cells. That makes ultimately, if we see that we can treat all these hallmarks together for each axis, immunization or immunosuppression, the stem cell axis, the metabolic cocktail, hypoxia, and neuron glioma axis, we have drugs that can modify these negative processes outside the psychoneuroendocrino-immunology axis, and very important also the gut-brain axis. So this is the concept that we have published in this manuscript. And it reflects a little bit to what has happened in childhood acute leukemia. Here a publication of 1968 and here a publication of 1980, where the pediatric oncologists have started to combine a lot of different drugs to make the difference and to let the children with acute lymphoblastic leukemia survive. Here they speak about the total therapy. Here in this phase, 8 effective drugs were applied to the patient's tolerance limits. So really at maximum in a non-randomized therapy protocol. They even could not eventually call it a study. But this combination approaches really was the start to make the difference for acute lymphoblastic leukemia. So if we have to do that, we need some requirements to get it realized. We need, of course, the expertise, not only in neuro-oncology and medical care, but also in translational medicine to get that all translated in the appropriate way. We need to have knowledge of advanced therapy medicinal products because we produce autologous mature dendritic cells. And we need, of course, to have the infrastructure, good manufacturing practice. We need to have knowledge about the regulations and the legislations. And we can do such an approach in Germany using the legislation framework of individualized treatment, individueller Heilversuch. This is even broader as the Right to Try Act that is now available in the United States. So at the legislation level, such type of approaches to treat patients are allowed by the legislative framework. And then if we see how patients find us, since we have the approval to produce our dendritic cell vaccine, then you see the highest need is in fact the domain of the neuro-oncology, much more than the digestive cancers, colorectal cancers, pancreatic cancers, more than the breast cancers, the urology, mainly prostate cancers, and then gynecology, uterine cancers, cervical cancers, ovarian cancers, and the pneumology, non-small cell lung cancer, small cell lung cancer, mesothelioma. But that are the spectrum of diseases that can be treated at the IOZK. If we now see what are the results, then we can look to the real-world data that we have sampled. What is the spectrum? In the literature, there were 5 randomized clinical trials in the last years, and the control arms of these randomized control trials were used as external control arm in the dendritic cell vaccine trial with from Northwest Biotherapeutics, so the DC-Vax brain. We can put the clinical risk profile, as I have explained earlier, the RPA classification, if you remember, from the data of our patient cohort. And we have published 50 patients in 2023, and we have expanded this group to 71 for publication in 2024. And at the end of 2024, I have further expanded the group now to the analysis on 90 patients that have been treated out of the more than 10,000 records in the database. I simply have taken this as selection variable so that there is no further influence on the data that we have derived out of the database. If we look to these patients, we have a median age of 50 years, which is a little bit younger as the external control arm, so the control arms of all these trials, which was 56 years. So maybe a little bit better in prognosis as if we think on the age, but it's more than 50. If we see on the sex distribution, then the sex distribution here is almost equal as here. We know that females have a better response to immunotherapy than males, but the sex distribution is equal. If we look to the Karnofsky Performance Index, then it is clear that our Karnofsky Performance Index is lower as compared to the external control arm. So this is a negative risk factor for our patient group as compared to this. If we then see to the extent of resection, so the percentage patients that got less than total resection is clearly higher in our patient group as compared to the external control arm. I get sometimes the critique that we have a selection bias in favor of our patients. But I think, as I have explained, it's in fact maybe the opposite. And we know from literature here published in 2021, where you can see that patients considered eligible for phase 3 clinical trials represent a highly selected minority of patients in a real-world GBM population. And it looks indeed that our real-world population has a worse clinical risk profile as compared to the highly selected patient groups in the clinical trials. Our patients come from several countries, which has something to do with feasibility of our treatment approach. And as you can see, UK is the highest group of patients that were in this cohort taken by the selection in the database. We have 38 MGMT promoter methylated patients, 52 MGMT promoter unmethylated patients. And just to give you an idea, I have made here a sort of swimmer plots in an other approach. Here you see the time of operation, you see the lifespan of the patient, and you see when the patient has died. And that's patient per patient for the MGMT promoter methylated patients, and here for the MGMT promoter unmethylated patients. Here you see we had more and more patients coming, and then you see the influence of corona, and now it's again that a lot of patients are coming in a fast velocity. And what you also can see is that here around 2017, 2018, we have further developed our technology, and these lines suddenly become much, much, much longer. Certainly longer as the expected lifespan, the median overall survival, which was published in the external control arm by the study of Linda Liu, here for the MGMT promoter unmethylated, and here for the MGMT promoter methylated patients. But of course, this type of presentation is not what we are used. We like overall survival curves. And here you see the data that have been published in the JAMA Oncology by Linda Liu. You see in black the external control arm, that is the currently accepted prognosis of the patient's MGMT promoter unmethylated and methylated. You see with the DCVax brain, there is not any difference at all for the MGMT promoter unmethylated patients, median overall survival and percentage 2-year overall survival, while in the MGMT promoter methylated patients, there is a clear shift in median overall survival, which was also significant, and there is also a clear improvement in the percentage 2-year overall survival. If we look to the data by Stupp, looking to the tumor treating fields, of which I think this is not only a cell cycle arrest, but also an immunogenic cell death effect, then you can see the published curves in 2017 and the clear significant shift in the median overall survival for the MGMT unmethylated patients and for the MGMT methylated patients. Also here, there is a clear shift in median overall survival, and the percentage 2-year overall survival increase in both groups of patients. The shape of improvement seems different in the MGMT promoter methylated patients as compared to the MGMT promoter unmethylated patients. I interpret that, but that's only speculation, is that the shift here may be more cell cycle arrest, while the shift here may be more the immunogenic cell death effect that plays on the long run, and that you have here maybe the immune escape from the tumor, so that here ultimately we lose these patients on the long run. When we at the end project our survival curves, then we can see for the unmethylated patients that there is a clear shift in the median overall survival, and there is almost a doubling of the percentage 2-year overall survival. And the same occurs in the MGMT promoter methylated patients. Be aware that our scale is going up to 84 months, while here only 60 months is presented. Also here you see a clear shift in the median overall survival, and you see almost a doubling of the percentage 2-year overall survival. However, we have to stress and keep stressing that observed is of course not evidenced. But for the patient, it's maybe not such an important issue if you observe how it goes 2 years later, 2.5 years later with this patient. Okay, it's not evidence, but it's nice to be observed it in this way. And we have published this patient because we saw immune-related effects along the course of the lifespan of this patient, which was even going beyond the IRANO criteria. So that means, as final slide, that we believe in this total treatment approach that we have to be implementing, like we did in leukemia in the years 60, 70, 80. Besides the surgery, the radiotherapy, and the chemotherapy, we can use target therapies. And here CAR T cells come as adoptive immunotherapy, eventually antibody-direct therapies, passive immunotherapy, but certainly also immunogenic cell death immunotherapy as extra anti-cancer approach using oncolytic viruses, biologic treatment, tumor treating fields, modulated electrohyperthermia as physics treatment. You have a direct anti-cancer activity, but you start already with treatment-induced anti-cancer immunizations. We should know that after the anti-cancer phase, we should block the freeway to death by repositioning the body against the newly formed tumor clones, and that is the immunization phase. For this immunization phase, 2 times the Nobel Prize has been given in the last years with the vaccine, active specific immunotherapy, and with the immunomodulatory strategies. If you get Nobel Prizes for this, somewhere it should have a meaning. And then finally, we know tumor cells can escape, so we need a third phase. So multiphase and combined, using in all phases immunogenic, individualized multimodal immunotherapy, that's not enough. You need also to treat the tumor microenvironment with tumor microenvironment therapies, as I have explained. And finally, at the moment, because we have problems with setting up the appropriate clinical trials, we should at least rely on well-analyzed real-world data to move the field forward in general. And I think that is where I will close my contribution, and I'm open for discussion.
Thank you. We've had a few questions here. So starting with the first one, at what stage of standard of care would you recommend that patients consider immunotherapy as a treatment option?
Well, already during the chemotherapy, as I have explained, I will go back to the general schedule because it's maybe a little bit fast, but this is the general schedule. Already during the maintenance chemotherapy, so after the radiochemotherapy, we propose to the patient already to start with immunogenic cell death immunotherapy, which is the combination of Newcastle disease virus and modulated electrohyperthermia. You kill cancer cells, but you kill also glioma cancer stem cells, and you change already the tumor microenvironment. So this is the first step of immunotherapy that is already inserted in the first line treatment, the maintenance chemotherapy. I have to make aware, I have not stressed that here, but the term immunotherapy is in fact a term that is misused. Immunotherapy is a sample term. And you always have to ask, what do you mean with immunotherapy? Here you see it on the slide. Here there is immunogenic cell death immunotherapy. Here there is active specific immunotherapy. Here there is modulatory immunotherapy. So you should not start modulatory immunotherapy with checkpoints during this phase. That makes no sense at all. You should start modulatory immunotherapy when you are really with the active specific immunotherapy after the chemotherapy. So it all depends on what do you mean with the term immunotherapy, and there are several modes of immunotherapy that all have their own place in the global treatment strategy.
Super. And do you have any patients who do both immunotherapy with the IOZK and CGAP? Can they be combined?
Yes, because as I have explained, the goal of both are in fact the same. Only the modality is different. But the point is really to get an answer an immunization, an answer from the body against the cancer. So it is perfectly possible to combine CGAT vaccines with IOZK vaccines. The type of antigens is different. The carrier is different. The danger is different, but the goal is similar. And personally, I would place these vaccines after the chemotherapy and not during the chemotherapy, because I think the chemotherapy as such lowers the effect of the vaccination, which is an active specific immunotherapy. That means you need an activity of your immune system. And if that is broken down by the chemotherapy, then your active specific immunotherapy will work less. That's also maybe one of the reasons why DCVAX brain had the problems with the MGMT promoter unmethylated patients. Also, they have combined the DCVAX brain with the chemotherapy. If you really look to their paper, there's a fantastic paper, their effects at the time of relapse was really much better in my eyes than the effects during the chemotherapy. So also putting the different vaccines in the global treatment strategy is really important, and one should take into account the particularities of each phase of treatment.
Great. You're going to have to forgive my pronunciations here because I'm not a medical person, so I'm going to give this my best shot. So it says, is IDH inhibitor vorasidenib?
Yep.
There you go. As effective in GBM as in LGG cases, according to the Indigo trial?
That is, of course, a question outside the spectrum of this topic. We only deal with high-grade gliomas, and in fact, with the IDH1 wild types, and not with the IDH1 mutated. So, in the novel classification of the WHO in 2021, they have made a clear distinction. It's another tumor, the IDH1 mutated. Astrocytomas grade 4 versus the glioblastoma, which is an IDH1 wild type. Within the IDH1 mutated, you have IDH1 long peptide vaccines, of which that's the 132H mutation. There you have an IDH1 long peptide vaccine, and indeed there the novel drugs like ivosidenib and vorasidenib, they are somewhere. Where are they? Here. So there is this link between the metabolic reprogramming and the immune system, and here somewhere these selective IDH1 inhibitors, which has something to do with the metabolic pathway, they play indeed a role. Whether these drugs are now more effective in higher grade IDH1 mutated tumors as compared to lower grade IDH1 mutated tumors, there I cannot answer because I have not these data right now in my mind.
Okay. This one says, in how many years surgery in GBMs will be limited only to biopsy and other job will be done by chemo-radio immunotherapy?
Well, I don't know, but it is for sure that if we look to our global model, this is the global model, this is still an enormous big enemy, which as such, due to the mass, already gives symptoms, but also changes the complete biology and even the systemic immune system. So whatsoever, I think I will always be in favor of getting maximal neurosurgery as first step. First of all, this is a medical treatment. Neurosurgery as medical treatment, it's maybe forbidden to tell it in this way, but at least it relieves symptoms very rapidly if you reduce the tumor mass when possible. But you do also a major biological step because you take away the source of the immune suppression and the whole dysregulation in the tumor microenvironment. So I doubt, due to the emergency relief of the symptoms and the biological effects, whether neurosurgery will be reduced to only biopsy. It might theoretically be possible that we start with the biopsy, that we do then some biological treatments in window, and that you then go to a stronger neurosurgery. But I think the time is absolutely not yet there. I think neurosurgery is an abrupt and very fast relief of symptoms, can be life supportive.
Actually, this is a personal question. I don't know the answer to this. Do you have, I know you have the graphs, say, for unmethylated versus methylated. Do you have any data on those that are able to have surgery versus those that are not? Is there any difference in sorry if I've missed that.
No. So here you see our percentage less than resected patients. You see our percentage completely resected patients, and you see here patients. These are real-world data where we did not find any report, and the patient did not tell to us. Now, to make the distinction between this, and this, in both the MGMT promoter methylated and unmethylated patients, then we come again to two small groups to see eventually a difference. The general credo, and that's always the reality, is patients that have a complete resection do better than patients that have a less than complete resection. Point. So therefore, any attempt to have a complete resection, that's always the pole position in the race.
Sure. Okay. Thank you. And we've got another question here that says, have you observed GBMs in the posterior fossa, and what age is your youngest patient?
Yes, we have observed 2 or 3 fossa posterior GBMs. They tend to do a little bit better, but I have faced with one patient then a spreading into the spinal canal, and then the patient has died of progressive disease. So maybe the location invites to more spreading along the road to the down. So our youngest patient, so in the database, as I have said, we have done a completely neutral selection. We have taken only adults between 80 and 70 years for this analysis. They should have been an IDH1 wild type. MGMT promoter status should have been known. Overall survival data should have been known, and they cannot be considered as second malignancy. We have, besides this selected group, younger patients, 14 years, 15 years, 16 years, also with GBM. Then the question, because there the classification has changed in the 2021, earlier that was a GBM, now that's a pediatric type diffuse glioma. So there the classifications have been changed. That's also the reason why I have left them out in this analysis, pure for adults. But we have had also malignant glioma or high-grade glioma in children, and the treatment approach is in fact similar, but there are too few to make bigger group real-world data analysis.
Great. I can't see any more questions. I think that's everyone, every question answered, should I say. So thank you very, very much for your time, Dr. Van Gool, and thank you to everyone who's joined us this evening. And if you've got any further questions, please do get in touch. Stefan, do you have a closing slide with your information on it so that we can share that with everyone in case anyone has any follow-up questions?
So this one maybe can be, so here you see in a very small area. So if there are questions, there is one email address, info@iozk.de. then it comes into one of the doctors who will reply. That's mostly me for the brain tumors. And this is our website here of the organization, www.iozk.de, where people also can find information. But for me, I think the most easy way is to approach me with an email. Next step, if it is not completely clear to me, we invite to do a short Zoom to see each other and to answer the first group of questions. And then from there, we go on with the email and we give the appropriate instructions to get it all turned into reality. And that's in fact still now never a problem. That always functions and always works very well.
Great. Thank you, Stefan. And we're getting some thank yous in the chat as well. So thank you very much for your time.
Yeah.
And again, thank you everyone for joining.
Okay, all the best. Good
Bye.
night. Bye-bye.
Good night.